Guys, can you leave them in?
We're live now.
طيب, are we live?
Yes.
طيب, بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It's our pleasure to welcome you to this interesting webinar. It is a journey throughout a long diffuse coronary artery disease. It is uncommon, but is a part of what we are seeing every day. So this meeting is meant to show you how to use the new technology, the different modality of imaging in assessing the coronary artery disease and to get the best result for the patient. A lot of cases will be presented today. Before we go ahead and start showing you how the expert hands tackle this kind of coronary artery disease, we'll go in a journey with a new technology, with a new stent. And Dr. Rasha Bawardi is very interested in this new technology, and she's the best person to present this stent and to show us what is unique about it. Dr. Rasha Bawardi, she's a consultant interventionist, consultant structural interventionist in National Guard Jeddah King Faisal Cardiac Center. And the floor is yours, Dr. Rasha. So don't feel shy, guys, to send us your comment, your question, and we're gonna after we finish, we're gonna do a good discussion of 30 minutes. Go ahead, Dr. Rasha.
Thank you so much, Dr. Khashqai, for organizing this session and webinar. I'm pretty sure we're going to have very interesting cases to discuss after this. Before we jump into the cases, as you mentioned, we'll just briefly talk about the Ultimaster platform, and the latest latest design is Nagomi. All right. So before going into Nagomi, I just want to kind of highlight some studies that were published already from Ultimaster, starting from a discovery, which was optimum vascular repair, moving on to real-world data with Sentry-2 and MasterDAP, which is the most important study. So discovery 1203, it was actually mostly to this. It's an in vivo to assess the stent strut coverage, which you can see that the coverage was up to 85% in the first month. So that kind of led to subsequent studies that we're going to talk about in a minute that talks about a shorter DAP duration. Sentry-2 was basically a non-inferiority, and most of these studies were done before the latest platform, and this was to other commercially available stents, and showed non-inferiority in terms of primary endpoint, freedom from target lesion failure, and it was a long-term safety and efficacy trial. The most important trial out of most of Ultimaster trials is the MasterDAPT, which was focused on high bleeding risk patients. It was an investigator-initiated randomized study. Not only it was a large trial, but also covered patients from Saudi, led by Dr. Asnaj at King Fahd Armed Forces. And it was pretty much all comers and patients with high bleeding risk. And they randomized them to 1 month, after 1 month, to either abbreviated DAPT with one single antiplatelet afterwards, or standard DAPT therapy, depending on the indication. And what they found is that in terms of NACE and MACE, it was actually non-inferior to the standard DAPT. But more importantly, in terms of major bleeding, it was actually superior with the use of abbreviated DAPT compared to standard DAPT. So non-inferiority when it comes to MACE and NACE, but better outcomes when you use the abbreviated DAPT in higher bleeding risk. So that actually led to the change in guidelines. So it's given class 2B with a 2B with a level B evidence in high bleeding risk patient to use either aspirin or P2Y12 inhibitor monotherapy after 1 month of DAPT. So why is that important? Because if you look at our PCI patients, 40% of those actually fall into the high bleeding risk. And it's also important for those who are, we don't know their bleeding risk. So those patients coming in with STEMI, they might actually fall into that category as well. So what is new with the latest generation of Altimaster? It's called Nagomi. It is actually, it highlights multiple things. So these are the earlier platforms. The Nagomi comes in with multiple kind of advantages with excellent deliverability, larger size line, and the most important thing is the overexpansion capability. So if you look at the sizes, it comes into three kind of categories. The new, which is small or large, and the older ones are considered the medium size. So the small size ranges between 2 and 2.5, and the overexpansion goes to 3.5. The older sizes were 2.75 to 3.0, and it actually expands to 4.5. And the newer, larger vessel design, which is very kind of important to majority of us, is 3.5 to 4.5, and the overexpansion goes all the way up to 6.25. It does have that flexibility before expansion, so it actually helps in terms of deliverability, especially in small vessel disease and calcified lesions. And the addition of additional crowns, so 10 crowns, helps with the expansion. And then aside from the diameter, they also come in longer lengths. So for diffuse disease, you can use one stent with a range all the way up to 50 millimeter in terms of length. In terms of other designs within Nagomi, it actually has a newer balloon with a better apposition in terms of expansion, so that will help as well as the hydrophilic coating, which facilitates the deliverability as well. There is ongoing trial with a post-market clinical follow-up, which we will have more data on in 2026. There was actually one publication that was done at EuroPCR, which is an e-poster, and it showed actually favorable outcomes with these. But obviously, this is not a comparison to other stents, but I think in 2026, we'll have better 2 years outcomes with a Nagomi stent. So with that, we conclude the overview of the Altimaster Nagomi platform, as well as the data from previous Altimaster stents. So we can move on to the
Can we, for the people who is, like to keep the volume down, please? So our next speaker will present a very interesting case, and we're going to stick to time, gentlemen, and we're going to show you how beautiful this stent can go from like the 2.5 and 2.5 millimeter, how they can go up to 3.5. And the 3 and 3.5 stent, they can go up to 5.5 and 6 millimeter. So without further ado, we're going to move to our next speaker.
Thank you.
ضيعت الشاشة سامحونا. دكتور عبد الله السعيدي طبعا he's an interventional cardiologist and structural interventionist again from King Faisal Cardiac Center Jeddah. Both Dr. Rasha and Dr. Abdullah is the rising star with a lot of complex cases and a lot of interesting cases. Go ahead, Dr. Abdullah.
All right, thank you very much, Dr. Wael. Thank you for the invitation. So I'm going to present the case today with you, and it's basically highlight the approach to lung diffuse coronary disease revascularization. So my case is basically, he's a 78-year-old male, no case of diabetes type 2, hypertension, and all stroke. He presented to our center with an stable angina. ECG didn't show anything other than normal sinus rhythm. Transthoracic echocardiogram showed preserved LV systolic function with no significant valvular disease. So his, as I said, his transthoracic echo, as you can see, basically showed preserved LV systolic function. There is some regional wall motion, basically the inferior wall with some inferior hypokinesis, mainly in the mid and basically apical segments. So basically his cath showed, as you can see here in the RCA, basically tight narrowing in the proximal segment. There's another tight narrowing in the mid and probably distal segment. And also, this is in the cranial view, you can appreciate the same lesions. And more importantly, there is no clear collaterals basically to the left side from this view. So his left system basically showed, as you can appreciate, the LED is occluded in the mid segment, and there is a tight narrowing in the basically mid to distal circ and in the ongoing OM. So this is the cranial views. As you can see, basically the mid LED, you can call it a CTO, although it's distally there is some flow, but probably this is from microchannels. There is some calcification in the proximal cab of that mid LED CTO. And basically, this is his coronary anatomy. Then based on this, his age and his comorbidities, so the decision basically was to proceed with complete revascularization. In his case, we basically elected to go with the LAD first, then stage PCI to LCX and RCA. So
basically, Dr. Abdullah, sorry for interrupting, patient was not good candidate for surgery and refused by too many centers. And you are now left with the only option being asymptomatic, which is PCI.
Right. So
okay, go ahead.
So another assessment.
Just another question, Dr. Abdullah. So before you go to do these cases, like what equipment you should have around?
Well, basically, I think the more you do complex cases, the more you have to have your basically elite, I would say, gear. Basically, you have to have the important thing, in my opinion, you have to basically prepare yourself first with basically lists of microcatheters, wires. Of course, you have to have basically the backup of, for example, talking about having a cover stand. And of course, you have to have the usual stuff, having 7 French catheters. You have to have also different surgery. You have a good surgical backup in case if you need anything happening in the cath lab. Okay. And I think more important to have, as you know, Dr. Kashgari, in our center, most of our cases, especially complex cases, we do it together. I mean, with Dr. Rashabwardi, with you. So always two operators better than one operator in the complex cases.
Well, I'm not interested in CTOs, but anyway, it looked great.
you did everything, mashallah.
Yeah.
So going back to this case, basically, it looks like tapered, if you're going to analyze it, tapered basically proximal cap. If you can see CTO, this view, there's basically, if you do, ideally you have to do contralateral injections as usual for CTO. But as you see in the RCA, although it was a short run, but there is no clear collaterals to that. So it's probably just microchannels. Anyway, it looks like relatively probably GCA's score of probably 1 to 2, I would say. There is some calcification in the proximal cap. So, but anyway, it's a long CTO segment. So we went ahead using basically, we started to do PCI to this LED. Our plan was to use 7 French guide EPU 3.0. Then our approach was to go, basically, there is no clear good collaterals from the contralateral side. So our plan was to go anti-wire escalation. However, if that's basically not successful, and maybe ADR or even STAR technique considered in this scenario. So we start by fine cross microcatheter, sign flu exchange, basically for field XT didn't cross, pilot 200 didn't cross. Then Gaia second basically made some progress. We managed to basically travel and puncture the proximal cap. Then basically in the body of the CTO, we continue to use Gaia second because it's a great wire basically to travel in the body of the CTO. And finally, basically, we managed to reach the distal end of the LAD. We confirmed that basically later on with the IVAS, but now we had the problem to not able to advance that fine cross microcatheter over the Gaia second. So we tried with crosshair through XS microcatheter, again, wasn't able. This plan, probably we need some support. We have an idea to use my basically guide catheter extension or to go with very, very small CTO balloons. In this case, we use the second option. We go with 1.0 by 6 millimeter. And once we inflated, basically, we faced difficulty to go in the mid segment more than the proximal cap. At that time, we faced some problem to advance this small balloon. However, we went up with high pressure, then balloon rupture. We did the, let's say, Carlino technique. And then we managed to basically advance the balloon to the distal end. We did the sequential balloon inflation, and we managed to basically exchange the crosshair Pro XS, using that to exchange the gas second with basically cyan blue wire. At this stage, basically we did an IBIS, and basically we are happy that we are in the true lumen, at least distally. And we basically did an IBIS at this stage to look for the reference diameter of the LED. This stage, the reference diameter of 275 in the mid segment, mid to distal. Then in mid segment, it was 3.5. And in the reference range, sorry, here it's 4 millimeter in the proximal segment. So it's a long lesion. And as expected, in the long lesions, you have tapered the vessel starting with 275 to 3.5. In this stage, we basically elected to use Ultimaster Gomi. We went with 275 50 millimeter stent, 12 atmosphere. That was actually enough to cover the whole lesion. Then we post-dilated with 3 balloon 275 15 and the distal segment 3.5 at the mid segment, and the proximal segment we use 4.0 NC balloon at 18 atmosphere. And this is our final results. We confirm our basically stent optimization using an IVL that showed basically good stent position and expansion in the full 3 segment. And the mid segment basically needs another post dilatation. We went also with 3.25 NC balloon, and we got this excellent result. So when we talk generally about sizing of the vessels, is basically, as we know, this is ABC in interventional cardiology, to basically size the vessels of the stent based on the distal reference diameter of the vessels. Then basically you go and post dilate in the proximal segment to avoid any stent under expansion in the proximal segment. And for that reasons, we have different post expansion stent limitations, and this depends between different type of stent and different length and diameters. And as we know, this is when we talk about basically predictor of in-stent restenosis, there are some patient-related characteristics, including age, gender, comorbidities, diabetes, CKD. Then lesions itself, like if you are dealing with small vessels, osteal lesions, high intimate plaque burden, or you have a previous ISR and calcified lesions. When we talk about the procedure itself, very important of basically a predictor of stent failure or ISR in the future when you're dealing with geographically mismatch or miss or overlapping 2 stents. So the more stents you use, the more ISR. And for that, we already explained beautifully by Dr. Al-Bawardi. We have the 3rd generation. We have 3 generations nowadays for Ultimaster Tennessee, and the Ultimaster Nagomi. And as Dr. Al-Bawardi showed beautifully, that if you go probably from 2 to 2.5, you can post dilate the stent up to 3.5. If you use 275 vessels, basically you can go up to 4.5 millimeter. And if you go and use 3.5 millimeter, you can post dilate up to 6.25 millimeter. So there are different sizes and lengths. When you talk about length, we have the new generation. It was almost now a year since that new length of 44 millimeter and 50 millimeter length stent has been basically introduced to the market. With that, I would say thank you for your attention.
That's an amazing talk, Dr. Abdullah. And you are nicely demonstrated that one long stent 2 to 5, it can go up to 3.5. What's unique about this stent is that, and we found it in our daily practice, and I'm sure Dr. Rasha Bawardi, she will highlight it at the end, and that the response of the stent to the balloon is 1-to-1. If you go 3-5, it will go 3-5. The most important is to use imaging to prepare the lesion properly. If there is a calcification, you have to use one of the modality to do, like debulking or modification of the calcium. The radial strength of the stent is really great. It's like if you put 2-to-5 and you go up to 3-5, the radial strength of the stent as if you put a 3-5 stent. Without further ado, we're going to go to our next speaker, Dr. Khalid Al-Harbi, consultant in interventional cardiology. This young chap, he's practicing now at one of the biggest center in the kingdom, which is what used to know as Shimasi, and now is the heart center of King Saud Medical City. And I visited them recently. I found a factory of cases. Go ahead, Khalid. You see, he's proud and he put his logo, man. Khalid, you can start. Khalid, ما بنسمعك. We don't hear you. Red Sands, can you check what's the problem? Khalid? Khalid.
Yes.
Yalla, you can
hear me
start.
now?
Yeah, we hear you, man.
Good. So when for a while, and thanks Dr. Rasha for this invitation, and thanks Tiromu also. So when they talk to me about long and diffuse disease, so I just found it's very difficult and it is very challenging. So still there is no precise definition of what is the long and diffuse lesion. There is many literature talk about that, but there is no what is the length and what is the diameter of the vessel of long and diffuse lesion. So if we have one coronary artery, we are expecting more than coronary artery are involved, as Dr. Abdullah Saidi case just showed. So let me start. I have 5 cases to be presented today. So the first case, this is a 43-year-old have any presented to our ERC angiogram showed unobstructed right coronary, and his left also was unobstructed, and also you can see there is a proximal occlusion and of the LAD. It is also so just try projection. Also, you can see here the ostial of is also diseased. So aspiration catheter, intracoronary glycoprotein 2B3A inhibitor was given, and also IV nitroglycerin also was given. Still diffusely disease from very distal to proximal. Then we did IVUS, which is very important just to clarify the distal landing zone and also proximal landing zone. So the proximal landing zone, we have fairly enough proximal landing zone just before the left main. And this is the final result. So we used long stent, I think 44. We just post dilate from distal to, and also I was just to confirm there is no pre or post stent dissection, and we lift the distal lesion just for for medical therapy. Second case, so we have a 54-year-old male who had a background history of diabetes and hypertension. He had a history of inferior ST elevation, had a primary PCI, RCA, and
خالد الصوت بيقطع شوية، ما ادري هو النت ولا السبيكر اللي انت بتستخدمه.
Let me just try, maybe let me use another one. Okay, let me...
So interesting. So the first case you used Nagomi in acute setting, not a stable setting, and which is also well described in the literature, and that Ultimaster also do good job in case of acute coronary syndrome, and it's non-inferior to any other stent.
Maybe just until you fix your audio, it was the interesting part of using IVUS in such cases. It's really important, as you said, sometimes we undersize in STEMI. So you can see that maybe some people would have picked a smaller size just by angio only.
Absolutely.
Okay, do you hear me now?
So,
Well,
يا عمي فرق كبير يا عمي كأنك جيت من المريخ.
Okay, good. Okay, so this is the next case. So this patient had an inferior STEMI, had a post-primary PCI to RCA, and now he came for stage PCI to LAD. As you can see here, there is diffuse also lesion from proximal to almost mid to distal LAD with myocardial bridge at that the mid to distal LAD. So we did IVUS, so imaging is very crucial in those cases. So we have a good or fair landing zone proximally, and we're just trying to avoid the myocardial bridging part of the LAD. And then we put one long stent just from mid to distal LAD to the proximal LAD, and then post IVUS just confirm there is no proximal or distal edge dissection. Especially in those long diffuse lesions. So we are just afraid from any dissection pre or post.
Khalid, would you tell us what is the length of the stent? What is the what is the actual size when you implanted? What it was?
So this is 3044 Nagomi stent. So we just post-dilate
with what?
3.0 and distally and 3.5 and 3.5 proximally.
Okay, go ahead.
Okay, so so this is the third case. So this is a 52-year-old male. He has a background history of diabetes and hypertension, and he was admitted with non-ST elevation myocardial infarction. He had long lesion of RCA, it's almost from proximal to distal. He had CTO proximal LAD, as you can see here from the collateral, from the RCA. So we did hybrid approach in this patient. We just did DCB for the distal lesion, and we put a 2 stent there in from mid to proximal LAD. Also, this is IVUS guided, and if you can see here in the distal, there is some small dissection, which is non-flow limiting. We just left it because flow is TIMI3 flow.
Can you tell us what is the sizes and the length of the stent, Khalid?
Yeah, so this is 3.5 in the mid RCA and 4.0 in the proximal RCA. We post-dilate with the 4.5 NC balloon proximally, and 4.0 in the mid RCA. And we use DCB 3.0 20 in the distal LAD, in distal RCA.
Do you use routinely IVUS if you're gonna post dilate to bigger size, like to 4.5, for example?
Yeah, 80 to 90% of my patient and our patient using IVUS and OCT imaging guided.
So that is now class 1 indication for stent optimization. For the people, the audience, I would like to know from
We lost the audio, right? Dr.
Yes, I don't hear him now.
If you want to continue
So,
your case.
until okay, so the fourth case, this is a 41-year-old male patient who was admitted with non-ST elevation acute coronary syndrome. He was discussed in our cardiac surgery meeting, and the patient declined coverage. So as you can see here, the patient has diffuse long lesion just from the distal LAD up to the proximal LAD. And then I just started that lesion, and you can see here there is still some waste in the NC balloon. So I just used IVUS just to clarify what I'm dealing with. So IVUS showed mixed plaque with superficial and also deep calcification. There is two area of stenosis which showed heavily calcified, more than 270 degree calcification. So next, we used a shock wave for this lesion just to prepare it and debulk it. And then we did IVUS post IVL, so just to make sure we cracked that calcification and to implanted a stent in this young male patient. So as you can see here, there is cracked of the calcium post IVL or shock wave. There's some deep calcification, but all superficial was cracked with the IVL. And also we have a good landing zone approximately just before the lift vein. And this is the result after drug-eluting stent. So here I used 3.5 long stent. We just post-dilate with the 3.5 distally and 4.0 proximally. And then we did IVUS just to make sure the position, the distal, and if there is any distal or proximal edge dissection. I think this is my last case. So this is a 41-year-old male. He had a background history of uncontrolled diabetes. He is a current smoker, and he was transferred from other peripheral hospital with inferior wall MI post-thrombolytic therapy. His angiogram showed unobstructed LAD and LCX disease, and he came to the cath lab for RCA PCI. As also you can see here, there is a diffuse long lesion of proximal RCA. It is extending from distal up to the proximal part of the RCA. Also here, with a high approach, I used P for the distal lesion. I used 25 3.0 DCB, and I used stent 4.0 and 4.0 in the RCA in the mid, and proximal RCA, and then we post dilate with 4.0 and 4.5 proximally. It's all IVUS guided, and I think this is the end of my cases. And thank you for your listening.
Khalid, Dr. Rashid, do you have any comment? It's amazing collection of cases, man. You covered the textbook. So we started with CTO with Abdullah. Now you showed us the stent and acute coronary syndrome. You showed us in chronic stable angina, and you showed us something like calcified lesion, and you see that the stent how is fully expanded, very good radial strength, well opposed. Khalid, thank you very much. That's not strange. You know, guys, you are doing a pretty good job at Shemesi. So our next speaker, Dr. Hamid, he is from Medina Cardiac Center. Medina, again, Dr. Muhammad Hamid, he's a fellow, is about to graduate. He will show beautiful cases. in acute STEMI and left main bifurcation. Medina Cardiac Center, they are one of the biggest in the kingdom, and they are going to host recently in December 4th and 5th one of the biggest meeting, Medina International. It's in collaboration with the leading and the biggest society in the region, which is the Saudi Arabian Cardiac Intervention Society. I call it the Society of Science. Dr. Hamid, the floor is yours.
Thank you, Dr. Well.
Next,
Thank you,
next
Dr. Well,
speaker,
for
guys.
these nice words. It's my honor today to share my case in front of this great panel. Today, we will introduce an interesting case of complex.
Show us the slides,
PCI.
please.
You can hear me?
Yeah, we hear you, man.
Okay. So we have here a case of complex PCI. It's I can call my case, it's the art of saving life. It's a very interesting case that was about to die, but thanks to Allah, He gave us the power to save the life of this lady. This case was done by Dr. Ibrahim Ali, our head of CAS lab in Medina Cardiac Center. I assisted him in this case. So let's go inside in a hurry. We have a 750 years old female. She has a history of hypertension. She came here for Saudi Arabia for Umrah. She's Indonesian. Just when she arrived at the airport, she has a gastric pain and vomiting. And in the airport clinic, they did an ECG which shows an inferior STEMI, and they sent the case directly to us for primary PCI. And this is her ECG, which show clearly ST elevation, inferior leads with Q wave, and ST depression from V1 to V5. When the patient arrives, at first, she was not willing to do the procedure. She didn't understand them well in the airport clinic. And due to language barrier, she was refusing and was reluctant to do the procedure. And all of a sudden, she collapsed the recovery area. She had a VF. We gave DC shock, CPR. Just one cycle of CPR, and she recovered. She recovered rapidly to sinus rhythm. And at this time, we took her directly to CAS lab course for primary PCI. Here we have to work fast. This patient had VF. And unlike the usual arrangement in primary PCI procedure, we didn't take an image for the left side. We went directly to the cause of her cardiac arrest. It's the RCA. The RCA was engaged directly with the guiding catheter. It's totally occluded. After passing the wire, fortunately, we have TME2 flow delineating a very long lesion. It will be clear when we made better engagement with the catheter. You can see here we have a long lesion in the RCA. Of course, in the primary cases, direct stenting is better to avoid microembolization of the thrombus and to decrease the nerve flow. And in many CAS labs who does not have this length of stents like 50, I think we have to put 2 overlapped stents. But thanks to Nagomi technology, they offered us the long 50 ml stent, and we did that at this time. 3050 stents was deployed directly at the lesion with a magnificent results. Here we can ask ourselves a very small question: what's the benefit of this long stent versus 2 overlap stents? Of course, avoidance of multiple inflation when doing a long stent is better to decrease the incidence of rare flow. No geographic miss, you will not take time to overlap cases, so sometimes you miss the overlap when a stent offers no geographic miss, and also shorter time of perfusion, provided that the delivery of the long stents is easy, and this is what happened. The stent was delivered so easy, deployed directly, and fortunately, we got a TME3 flow in this big RCA. Now, we did the job for the primary cause of this with a long Nagomi stent. Then we have to move to the left side after finishing the job here, and we find a surprise there. We have a very tight distal left main with a little bit healthy LCX, only the proximal segment is diseased, but LED has a little bit long disease. Here in this cranial view, we can appreciate that distal left main is thrombotic. There is hazy distal thrombotic lesions in the left main. We decided to complete the revascularization now. First of all, this patient is 75. She's not a candidate for surgery. Second, she's an Umrah patient, and there's special circumstances that you need to finish the job in a shorter time to catch their Umrah and go home. And of course, I know this will be an area of debate to do this lesion at once or to make it staged, but you can appreciate that this distal left main is hazy and thrombotic, and we are afraid that it may close. And of course, this is what cause sudden death. Now we proceeded and we decided to do a decay crush technique for this left main LAD LCX lesions. And let's summarize the steps of this long, complex procedure, but thanks to Allah, it went easily. First of all, the first step to do this decay crush technique is to wire both vessels. Then to do a predilation of the main and side branch according to what's needed. Here we decided to predilate the more tight distal left main with the ostium of LCX with balloon. This is the second step, ballooning of the side branch. Then we put Nagumi stent 3/0 by 24 in the side branch, preparing 1-to-1 size balloon, NC balloon in the LED for crashing. And this is the third and fourth step. We did stenting to side branch and we delivered the balloon for crashing. Then we did the crashing by this NC balloon.
What was the size of the balloon you crushed the stent with?
It's 3/0 NC balloon, 3/0 NC.
Excellent.
There is some debate in this step to crash the wire or not, but usually we prefer to leave the wire in place and do the crashing. I know some interventionists prefer to crash without the wire. It's not a big deal.
Let me tell you the truth, Dr. Muhammad. I will definitely pull the wire for too many reasons. One of them, if it's a BT choice, it will be broken. And we don't know too much data about the new wires, like the run through, the the other run horse, working horse wires. But BMW is not an always like a guarantee. It will not be be difficult to take it out. The other thing is the material covering the stent. It will be slipped out from the it's going to be nidus of thrombus. So I even we were in a conference in the Euro BCR, and they did a vote. It's only minority they leave the wire. So it's always nice to remove the wire. It will not help you in anything if you keep it. Go ahead.
You're right. So we will not do this again, inshallah. So we have crashed the stent. Then this is the 6th and 7th step, recrossing to the side branch first, doing a kissing balloon for the main vessel and side branch. And this is the first kiss in the double kissing technique.
No bot before?
Here we don't have a stent in the main vessel yet, so we didn't do bot.
Not yet? Okay.
This is the first kiss after recrossing to the crushed stent, doing kissing. Then another Nagumi stent was deployed in left main LED, covering the whole LED lesion. Really, when you are doing this step,
because it's an educational case, so I'm interrupting you a lot. The view on the left side, what it was, do you remember?
LAO cranial. This is an LAO cranial view.
So that's a very smart. You go LAO 20, cranial 40, 45, and I'm sure you did this. You did this. You go, yeah. So cranial 20, 25. Write it, guys, down, and the LAO extreme like 40, 45. I don't know, Dr. Rasha, what do you think? He marked the tip of the stent at the superior part of the left main or the inferior part of it, like the superior, let's say, roof or the inferior roof?
You want to make sure you cover superior because it's outer in this case.
Exactly. So, guys, we used to do it with the inferior, and there was a lot of mismatch. Now, most of the people advocate is to go with the superior. Can you put the can you freeze it and you show them what I meant by superior?
Yeah, exactly. Thanks for this important notice, Dr. Wael. As you say, that this is the best view to clarify both lips of the left main. Here is the inferior lip of the left main. And here is the superior.
This is, keep the arrow on the superior, please.
Yes, here.
Yeah, so this is the superior. Where is the inferior?
Yes, exactly here.
Absolutely. Thank you very much. You can move on. I like how it is, stable, the stent even with this left main, and it's sometimes the stent when it is ultra thin, it move a lot.
Yeah, yeah. This is one
Go
of
ahead.
the.
So this was what, 3?
There is a CO stent, and of course, in this step, we are searching about the stent that have good expandability. And this is one of advantage of Nagumi, that this 3O stents, we can make it up to 4 or 5 in the left main.
Up to
By the way,
6. Yeah,
there's an
it can go
Indonesian
up to, yeah,
4 or 5. This is
4 or
3O
5. Yeah.
stent. This is an Indonesian female lady. She is low body mass index, so I think 4 or 5 left main is accepted. And here we did the first spot after stenting the main vessel. This is a 4-5 in C balloon. This is
Excellent.
and then again, we need to do the secondary crossing towards the side branch. Then the second case is also the same balloons. We did this.
So what balloon you use? What is the size of the balloon in the CERC and the LED?
We used 1-to-1 size in each vessel. So in LCX you have CO stent, in LED you have CO stent. So we choose CO and C balloon for each vessel. 1-to-1 size for each vessel, and it will fit the equation of 2/3 of the left main size.
Which is going to be 4.
Exactly. For 5 left main.
4 or 5, yeah.
Yeah. So now we did the step recrossing and the second case, and finally we did final bot for with the same 4-5 in C balloon. This is the final bot. Here we have finished the steps, but we noticed that it is a calcific vessel in LED and LCX, and we decided to do IVUS study for both vessels. Unfortunately, the IVUS picture is missing, but it shows that there is some areas of under deployment in LED and LCX, and we did 3-5 in C balloon in both, away from the carina. The carina was well done, and the left main stent was well opposed. I'm sorry that I couldn't retrieve the IVUS images, but we did both stent and optimization for both stents away from the carina, and this is the final results.
Inshallah. Amazing.
In
Amazing.
cranial view. Dr. Brahim asked me to add this photo, and finally the patient was very happy before going to finish her Umrah.
Oh, that is my friend, Dr. Ibrahim.
Ibrahim Ali was the operator.
Yeah, he's a senior interventionist. So, Dr. Rasha.
Yeah, we got a couple of questions from the audience.
Go ahead.
Too. It's interesting, you know, it's not an easy decision. I understand why you went with the RCA immediately, but in retrospect, taking a quick look at the left main, would that have changed your mind and just ballooned the RCA and got a surgical referral at that moment or not? That was one of the questions from the audience, probably.
Yeah, I think this is one of the options of treatment of this case, and this case has special circumstances that make us doing what may look little bit unlogical. The first step that the patient has a cardiac arrest in front of us, and you have to revascularize, and you can see the left main looks thrombotic, and this is what pushed us to do total revascularization is the cardiac arrest. The second thing is that after reviving the circulation, blood pressure was maintained. She was not in cardiogenic shock. And also the third, that she's a little bit old lady. And also, you know, in Medina, we are facing a lot of these circumstances of Umrah cases, that this has a special situation that this patient stays only for 4 or 5 days in Medina. Of course, if the patient cannot be done by revascularization, we have delayed the flight of many cases, and we did coverage for many Umrah cases. But we decided a little bit among the interventionists in our cath lab that if BCI can done, we should do it, because most of patients refuse coverage. Most of patients have a question: how many days I have to stay here in Saudi Arabia? I need to go to my country. Coverage, many cases refuses coverage, and in this case, while this here syntax score is a little bit, I estimated it's a little bit high, 35, but she's 75. She a little bit old for surgery. The issue of Umrah case, and also the cardiac arrest that happened in this, and of course, it's the main cause is the total RCA, but also she has a thrombotic distal left main. You know, if left main doesn't look that thrombotic and that tight, we may even stage this left main for another procedure or even at home country. But really, we had the fear that left main may occlude later.
Yeah, it's a difficult situation. I understand with the Hajj and Umrah, it's always difficult in terms of timing, but typically the usual teaching is if someone is in shock, you treat the culprit, wait, and then treat the non-culprit vessel.
Sure.
But-
Did this patient refuse procedure initially, or?
Yeah, initially when she came from airport clinic, unfortunately the Indonesian people sometimes we didn't find easily a translator. She didn't know why she's here, what's the type of the procedure, what she was in an anxious state, what you are taking me for. So we asked her to bring one of our workers. She can speak her language. While you are doing this, takes a little bit some time. She has a cardiac arrest, and of course after this shock and CPR, we directly took her to the cath lab at once.
Yeah, so basically you didn't really have an informed consent to say that she refused because she didn't really understand the language. And now you're faced with an emergency consent, I
Yeah.
believe.
Sure.
Yeah, Rasha, I have a question for you.
Yeah.
Being that this stent, more than me, what about that? Patient she's going back home. The data from the Ultimaster, I think, is encouraging for early stop of Plavix in case something happened. Or what do you think?
Yeah, so I think we talked about master DAPT, that 1 month of DAPT is actually superior when it comes to bleeding. And this is for high bleeding risk patients, which is pretty much a lot of patients that we see because their high bleeding risk criteria is actually not that extensive. But I think it's more important for people that we face in Hajj and Umrah because we don't really know the availability of those medications outside. We know that aspirin is available pretty much everywhere. So it's probably a preferred approach to use any platform with safe, shorter DAPT in these patients. For the interest of time, I think we have a few more questions, but we'll leave it at the end. We're going to move on to our last speaker, Dr. Waqar Ahmed from King Fahd Armed Forces, a well-known senior cardiologist with great expertise in complex intervention, especially CTOs too, who is going to present another case of the use of Ultimaster.
Okay, thank you. Assalamu alaikum, Dr. Rasha and Dr. Weil for inviting me. I'm actually in the hospital because this case was actually done on Thursday and I didn't have time to prepare the slides for it. And it's easier to just present it from our server at the King Fahd Armed Forces Hospital. So this is a 59-year-old patient with hypertension, dialysis, underwent mitral valve repair, tricuspid valve repair, and vein graft to the right in the circumflex in 2018. Recently has been having chest pain, limiting his dialysis severely in the hospital. He underwent CT angiography by his referring cardiologist that showed completely occluded vein grafts, and his echo ejection fraction is 55 with good valve repair. So I'm going to now go to his angiograms because it was done in 2 stages. The first stage was done a couple of weeks ago, and the other procedure was done just on Thursday. So this is an angiogram. Do you see the angiogram? Because I'm flipping between the PowerPoint to our... Do you see the angiogram?
No, we're actually just seeing the PowerPoint. So maybe...
Okay, so let me just stop share and re-share this because we were trying to play with this. Okay. How about now? Yeah.
Yes. Yeah, we see it.
Okay, so this is a CT of the right coronary artery. I had the advantage of seeing his 2018 films. This was an occluded right coronary, but was a very easy right coronary in 2018. But as we know that once CABG happens, simple lesions become very advanced CTOs. So, and there it is. It's essentially a JCTO3 CTO. And he's got a very large codominant circumflex that is supplying epicardial collaterals to the right. The LAD only had moderate disease. So let me just go to number 10 because I have put them all. So this is the wiring. Here it is. Here's the best view for this circumflex that's supplying the epicardial collaterals back to the right coronary. And this shows you the double bend of the circumflex from the left main back into the circumflex. So this is just a workhorse wire going down a ski slope, essentially, and was able to wire this vessel without too much problem. And so here's the wire that went. I actually wanted the wire to go back into the distal PDA, which it did. And the next view, sorry, is after pre-dilatation. I wanted to show you, this is the Nagomi stent, how flexible it is in going down this extremely tortuous vessel, turning, making all the turns, and it went down. I took down 2 stents. I took an 18 millimeter 2.75 and a 3.0 15 based on IVUS, mainly because I did not want to push a very long stent down. So that was done. So I will now go to one of the final pictures. So second stent was placed, dilated, and we got the final angiogram and post-dilated, and hopefully, yes, this is the final angiogram. And you can see the filling of the right coronary. So this patient, I brought him back this week. And now I'm going to go to this week's angio. Okay. So let me know if you see the angio, hopefully. Yes.
Yeah,
You
we
see
see,
that?
we
Do
see
you
it.
have the angio?
Yeah.
Okay, so this time I was going after the CTO, so it's the femoral slash radial access. Let me go to the second. So this is the standard setup shot for a CTO. I call it AL 0.75 and an XB 3.0. So this is the right coronary. The CTO is up here. There is a little island, and then it's CTO, and then epicardial collaterals filling the PDA and PLA. So here's that CTO of the right coronary. So I set it up. I have the retrograde wire. It's such a big epicardial collateral that it was very tempting to park a wire there, at least to use it as a marker wire. And here it is. And I started antegrade. And we went down. I had Dr. Sultan Al-Ataibi, my colleague, assisting me, and we went down. So I have the marker wire distally and went down with the Fielder XT, and then a Gaia second. And I wanted the 2 wires to meet and be friends, but they would not meet each other. I tried my best. So I gave up the antegrade and went retrograde. So I changed the wires from retrograde from a workhorse to a gladius wire. And the gladius wire, with pretty much gentle manipulation, went up, and I was able to capture it in the guiding catheter. So here we confirmed we're up there. I tried to be a little cute here. I did a tip-in. I did not want the epicardial collateral to have a lot of tension with a wire that's externalized. So here's the retrograde microcatheter in front of the antegrade microcatheter, and the wire is going from the retrograde microcatheter inside the antegrade microcatheter inside the guiding catheter. So once it's in, then here's the wire going up from the retrograde microcatheter to the antegrade microcatheter. But unfortunately, once I came down, I could not push it through because the CTO was pretty tough there. So I had to externalize. And let me go to number 18 now. There we go. So once we externalized, this was the diseased vessel. This is the entire vessel is diseased, and it's a CTO from proximal to mid, all the way to distal. Of course, intravascular ultrasound was done after pre-dilatation, and this picture is after pre-dilatation. So there's not much flow. So here's the first Nagomi stent. This is a 2.5 by 38 Nagomi. By intravascular ultrasound, this vessel was about 3.0, but I took a 2.5. I've become conservative. I've had perforations by going EEM and sizing. So I go one size less.
Sorry for interrupting you. Do you feel any difficulty advancing the stent? It's a long stent. Is it like, how is the deliverability of the stent?
Very easy, because there was not much calcium here. So delivering the stents was not a problem. We already had a 7 French AL 0.75 guide, so it was giving us good support. I had flipped because I did not want to leave the externalized wire in the epicardial collateral. So once I had the microcatheter down, we switched back to just an antegrade workhorse wire. So that was the 38 millimeter Nagomi stent. That was followed with a 3.0 32 millimeter Nagomi stent overlapped. So 38 plus 32 is about 70 millimeters of stents here. And I will not waste time showing just, we did IVUS, we did post-dilatation, we did IVUS, we did post-dilatation. And this is the final angiogram. So this patient is now completely revascularized. We revascularized his circumflex 2 weeks ago, and today we revascularized his this is our stent boost of the 2 stents overlapping. It's difficult for stent boost to work when there are multiple surgical wires, but here it is, the 2 stents overlapping and going.
What is the biggest balloon used in this case? Like for
3.5. Proximally, we went 3.5.
Wow. So
I undersized with the stents, but post dilatation was 3.0 and 3.5.
And the apposition was good?
That position by IVUS was good. If somebody really, really wants to be bored, we have an excellent pack system. And if you really want to be bored and you are an IVUS nerd, we can show you the IVUS. Do you see the IVUS? Do you see the gray screen? The IVUS takes time to load because these are huge, huge
No.
files.
We
No?
only, yeah.
1 second, stop share. I just have to reshare this screen again. There we go.
While you get those slides, oh, here, yeah, now we see it.
Yeah, so this is the IVUS going from and proximal. This is pre-post dilatation. And here's the stents. Once we place the stents, we post-dilated with the nominal balloons. And then after this IVUS is when we go back with the final balloons we use. So there's the IVUS from all the way from distal to proximal, and you can see the bifurcation. There's an area that comes the bifurcation just before the stents pretty nicely. So the initial stent, remember, was 2.5. So here I post-dilated with 3.0, and the proximal stents were post-dilated with 3.5. So I'm going to stop share. So the patient got the stents, got revascularized. My own database of stents, I never write what stent I use. So when somebody said they want Nagomi stents case, I didn't even know which case I had. And by luck, this is the case I did this Thursday.
Excellent. Very, very complex case. And I think you've demonstrated that the use of Nagomi in such cases, the tortuous anatomy in the circ and a CTO of RCA. We've got a question from the panel about the indication for the CTO. Was it angina, or what was the indication for the RCA?
Severe angina. The patient could not complete his dialysis sessions. Every time he was dialyzed, he was getting chest pain. And that's when his non-invasive cardiologist did the CT, did all the preparation that showed that he has the CTO, a tight lesion, and all the vein grafts are gone.
And maybe a question for you. It's actually for Dr. Abdullah Saeed, but you could also answer as well and have both of you comment on it. Is your approach for CTOs? Do you use radial with a slender, or do you typically use a femoral upfront?
Basically, it depends on your, I think Dr. Waqar, maybe nowadays all cases by radial, but depends on your experience. But nowadays we start to use more and more biradial. If it's male, most male will accommodate 7 French cylinder. However, in female, basically around 60 to 70%, these data from Western population, they will not accommodate 7 French cylinder. So I think it's useful sometimes to use ultrasound on radial arteries, basically before the procedure, to see the diameter of the radial artery. And if you have at least 2.5 diameter by IVUS, then probably will accommodate 7 French cylinder. So ideally, if you're, starting your CTO program, probably go femoral. However, with more cases you'll do, basically by radial may be better, approach for these cases. What do you think, Dr. Waqari? Your opinion?
I agree. I think when you're starting, it's better to go 7 French. And if you can get 7 French via radial, that's fine. But our patients are small. And that's our biggest problem, is sometimes even getting a 6 French guiding catheter in a radial artery is tremendously difficult. So most cases I have are 1 femoral, 1 radial. And I have cases by radial, I have cases by femoral. So it's case by case basis. It depends on the radial arteries. Ultrasound really helps. It shows you the size of the radial arteries. So I think just go case by case basis.
And a question about contrast. I think, you know, some of the lots of CTOs, people are trying not to use a lot of contrast. The more concern is more with radiation than contrast. But how was this case in terms of contrast and radiation?
In terms of this case, the contrast was 210 cc's. We were a little liberal with contrast because the patient was already on dialysis, and we knew he was going to be dialyzed immediately. Radiation, we are very conservative with radiation. We only do setup shots with the high dose radiation. After the rest of the case, we try to do with on the Philips machine with the low fluoro and 7.5 frames. Only when we need to go to medium fluoro or 15 frames, we go that. So we try to keep radiation, ALARA, as low as possible.
And we've got a question to you and also to Dr. Muhammad for your case with the VF arrest and left main. Did you use any mechanical circulatory support throughout the case?
For me? Okay. No.
Dr. Muhammad Hamid first, think about his VF, and then we'll come back to you, Dr. Waqar. If Dr. Muhammad is not with us or his mic is muted, for you, Dr. Waqar, there was a question about CTO cases. When do you choose mechanical circulatory support?
I think, again, it's a case-by-case basis. It depends first on the patient, ejection fraction. If it's a low ejection fraction and you're going to go retrograde through retrograde collaterals, that may get ischemic and compromised while you're doing it, you definitely should consider some form of mechanical support. I did a patient once where I was going septal to septal, LAD from the ipsilateral septal to ipsilateral septal collateral. And every time I entered the proximal septal, the patient just went hypotensive and ischemic. So those are the patients. And the other patient that you would consider that is a patient that it's a CTO and the LV reserve again is low with heavy calcification, and you think you're going to end up using a rotablator. Those are the patients I would definitely consider having mechanical support available, because those are the patients that may go into seriously no pulsatile flow during rotablation.
And Dr. Muhammad, for your case, the VF.
Yeah, but this case, hemodynamics was good. This is why we didn't use mechanical support in this case. We judge both the LV function and the hemodynamics. As I told, this patient was not a cardiac shock. His main blood pressure was around 75, so this is why we didn't use. But of course, if patient with cardiac shock and low ejection fraction, I remember last week with Dr. Ibrahim Ali also, he has used the Impella in young man. He came with anterior STEMI 40. He was only 40 years, but his mean blood pressure was around 40. So we used the Impella in such case.
Excellent. Dr. Waqar, you've shown very nicely how you've used the retrograde collaterals, but they're epicardial collaterals. I know a lot of people are scared of using those. So tips and tricks in terms of wires and microcatheters to use in such epicardial collaterals. You're muted.
I am very scared of using epicardial collaterals. This was the case. The epicardial collaterals was very mature, very large, so I felt comfortable using it. You only use soft wires through epicardial collaterals, and this, so it's like SU03 or Zion Black. You do not inject. You do not use microcatheters that are torquing. You do not use high tension in these, and you try to, once you're done, you try to get out of it very quickly, and you have to have coils in your cath lab to be able to control any bleeding. If the epicardial, especially post-CABG patient, if epicardial collateral bleeds, and if you cannot stop it, there is nothing much even a surgeon can do at that time, and there won't be enough time. You better have coils to close them.
Great. Yeah, a very excellent point. I agree. I think we've nicely demonstrated the use of this platform in multiple lesions. So starting with long diffuse disease and mismatch in terms of sizing. We've talked about calcification. We've talked about the use of it in CTO, in tortuous vessel, in heavily thrombotic lesion, VF arrest, where you don't want to do multiple ballooning, and also in setting of multiple ACS and mostly STEMIs with imaging that Dr. Khalid showed. So really nicely variety of cases with the use of this platform, and we've got greater shorter adapt duration data on it too. So any final comments from the panelists and the speakers?
If you allow me, Dr. Rasha, one of the important things about this the stent is like what you showed us early in your excellent lecture, and what the colleague they showed us in the during the case presentation. It is a great platform. When you face a long diffuse coronary artery disease, for example, distally is like it look like 2 to 5 or 2, and then proximally you don't know what the actual size, but you are quite sure from the normal segment or the size of the patient that it's about 3 or 3.5 or even 4, as shown by Khalid Al-Harbi. And so this is the platform that I really I would like to use. The preventing edge dissection. Then the rest of the artery you can deal with it by different balloon sizing. And for sure, in this kind of lesion, you have to use IVUS pre and post. I know Dr. Rasha, because I'm working with her, and Dr. Abdullah Saeedi, they love IVUS, and actually our complex cases and cases in general approaching 60 to 70% the IVUS. And the stent is easy to deliver. And more than that, it's the speaker, they showed us different pathology that the stent work well: acute coronary syndrome, stable, CTO, calcified. So that's the point I would like to mention. So maybe there is a couple of questions from the audience, and then we're going to conclude, Dr. Rasha. Thank you for you sharing this great session. And as always, when you are sharing, Rasha is like, it's a great meeting. Thank you for your effort.
No, thank you. Thank you so much for organizing it. I think one last comment again for, I think we kind of commented on it earlier. Dr. Nasser was mentioning for your case, Dr. Muhammad Hamid, if you were to go for CIRC first, look at it before injecting the RCA. I know these things in theory, we always look for the non-culprit, but we can't imagine being in your shoes with someone already arresting VF, and you're just trying to open up the vessel of the culprit immediately. But there's actually one trial that looked at this, and it's really not much of a time difference when you compare looking at the non-culprit with the culprit. But whatever you do in this case, I think the PCI would have been the option, given that no one is going to take her with a VF arrest to the OR. Any final comments from the panelists or from the speakers? Dr. Waqar, I think.
Thank you very much. No, just thanking everybody.
Thank you so much. And we've highlighted again just the use of Ultimaster, but most importantly, we've highlighted different strategies to approach complex lesions, from imaging and sizing and using the right platform, which is of wires and guides and catheters. I really like to thank all the speakers for their amazing effort presenting us really high quality cases, and for Dr. Qashqari for organizing this webinar. Thank you all, and we'll see you soon on the next webinar.
Thank you.
Thank you very much, Doctora. Thank you.
Okay.